This is the mood disorder lecture for examination 3, nursing 592 and 692, module 7. Mood disorders can be found in chapter 51, starting on page 3674. Mood disorders encompass depressive disorder, disruptive mood dysregulation disorder, mood depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance medication-induced depressive disorder, and other specified and unspecified depressive disorders. We'll start off by talking about depressive disorders. For pediatrics, they should have 4 of the following major depressive disorder symptoms, which include weight loss and weight gain. They may have an increased or a decreased appetite. They may have insomnia or hypersomnia. They may have a psychomotor agitation or psychomotor retardation. They may have fatigue or loss of energy. They may have feelings of worthlessness. They may have excessive or inappropriate guilt. They may have the diminished ability to think or concentrate. Now, for a child to have a diagnosis of a depressive disorder, it has to be in the category of depressive disorders. There cannot be a history of ever having a manic or hypomanic episode, which we will talk about a little bit later in this lecture. So when we talk about depressive disorders and their symptoms, they may have recurrent thoughts of death. They may have suicidal ideations. They may have suicide attempts or a plan. They may have social withdrawal. Children display their depression differently. They may have irritability. They may be sleeping all the time. They aren't usually vocal about their symptoms, and oftentimes their parents may not understand their depressive symptoms. These symptoms must be present that we've talked about, including a depressed or irritable mood. They have to have a loss of interest or pleasure, and this must occur over a 2-week period of time or longer. So if they have something going on for just a couple of days, goes away, parents won't be as concerned. Normally, by the time a parent brings their child into the clinic, it's been well over 2 weeks. And these feelings must cause an impairment in functioning and must cause significant distress. So what are some of the risk factors for depressive disorders in children? Well, there could be parental substance abuse. There may be poor marital adjustment. There may be a parent-child conflict. There may be lack of family cohesion. They could be being abused, neglected. They could be experiencing the death of a parent. Cigarette smoking can contribute to depressive disorders in children. Physical illness, maybe their functional environment. It is thought that prolactin may be released in depressed children. So there may be a greater release of prolactin in depressed children. So what are some of the other risk factors for depressive disorders in children? They could have medical conditions, seizure disorders. They might have MS, hypothyroidism, Cushing's, pneumonia, AIDS, mono. Also, if parents are diagnosed with depression at a young age, then their children have an increased risk for depression. So let's talk about their physical exam. You want to interview the parent, the child, or the teen together. So normally you can start off with them together in a room, kind of get the child to warm up to you a little, or the teen. A lot of times that teen or that child won't say a lot in front of that parent. So you also want to interview them separate. So this does take a bit of time. Sometimes I'll start off with both of them. Sometimes the parent wants to start off first, giving you their take on the child or their teenager. But I do like to have them together so I can see if they agree or disagree on what the other is saying. And then I like to have them separate, of course, because the parent's going to tell you things that they may not want to say in front of their child or their teenager. And that teenager may tell you some things that they don't want to say in front of their parent. There's different screening tools that you can use, like the Child's Depression Rating Scale, Revise, the CDRS. That is a 17-item scoring tool. It scores cognitive, somatic, affective, and psychomotor. If they score greater than 45 on that test, it is clinically significant for depression. There's also the PHQ-9, which you can use on your first visit, and that tracks their responses over time. And it is based on the last 2 weeks. So it always starts off on the last 2 weeks, and we start asking them about the different questions that they may or may not be experiencing. Some of the things that we ask in the PHQ-9 are, let's go ahead and give you a couple of those questions. Over the last 2 weeks, how often have you been bothered by any of the following? Little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling asleep, staying asleep, sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, that you're a failure, that you've let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching television, moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you've been moving around a lot more than usual, thoughts that you would be better off dead or hurting yourself in some way. To interpret your PHQ-9, anywhere from 0 to 4 is no depression. If they have a 5 to a 9, it's mild depression. 10 to 14 is moderate depression. 15 to 19 is moderately severe depression. And 20 to 27 is severe depression. Now, how is it treated? How do we treat depression in children? There is a dosing chart on page 3679 that I would like you to be familiar with. I did not copy it here because you all have the book. The dosing chart is on page 3679. So, of course, first-line treatment is going to be cognitive behavioral therapy or interpersonal therapy and interpersonal psychotherapy. If you're going to use medications, because of course therapy is not going to work for everybody, you may need to resort to medications, and I like to tell patients that medication and therapy work hand in hand when it's time to start a medication. Fluoxetine is used for children over the age of 8. And escitalopram is FDA approved in children over the age of 12. Tricyclic antidepressants are not effective for children. Now, before you start a medication on a child, you do want to get informed consent. You also want to let the parent and the child know the purpose of the treatment, describe the treatment and what your plan is. What's the process? What's the benefits and risks of the medications? You always want to give them the side effects of the medications, and you want to document the side effects that you have told them about. You want to talk to them about alternative treatments and also unknown risks. There are stages of treatment for the medications. So the first stage, is you're going to start off with an SSRI. If that SSRI is not effective, you will use an alternative SSRI. If you have tried an SSRI, you've tried an alternative SSRI, neither of these are effective for this child's depression, you want to use a different class of antidepressant, which we would either use venlafaxine, bupropion, mirtazapine, or duloxetine. These are for children and adolescents. So, say you've done an SSRI, you've tried a different SSRI, you've even gone to a different class of SSRI, and this child is not having any improvement. This child is already in therapy. At that point, you need to do a reassessment of the diagnosis and do a treatment consultation. Now, say this child has been depressed for a year or more, still depressed. They're showing some improvement, but they are still depressed. At that point, that child has a dysmic disorder. So for children, it is symptoms of depression for 1 year, and it's 2 years in adults. Now we'll move on to disruptive mood dysregulation disorder, which is a new DSM diagnosis. And this is used because it avoids us over diagnosing children with bipolar disorder. So what are the characteristics of the disruptive mood dysregulation disorder? Verbal or behavioral temporal outbursts, and they are having excessive age-inappropriate outbursts, and they're having 3 or more a week. They may be irritable and angry. And if they are, this has to be in more than one setting. So this child can't just be very irritable and angry at home. This behavior also should be in one other place. So maybe they're behaving this way at home and at school. They could be behaving this way at home and with their peers, but it's got to be 2 different settings. Also, they have to have 12 months of this behavior without 3 months of symptom-free behavior. So it's almost like women with menopause. You have to go a complete year without a cycle to be in menopause, because if you have a cycle 2 days before that 1 year, well, they're no longer considered you in menopause. So this is the same with these children. If they go 4 months, but 8 months of the year, they have had this outrageous behavior, well, you cannot say that it's disruptive mood dysregulation disorder, because again, it has to be greater than 12 months without 3 months of symptom-free behavior. And the age of onset for this is before 10 years old. That's the age of onset. But you do not diagnose a child with disruptive mood dysregulation disorder before the age of 6 years old or after the age of 18 years old. So the age of onset's usually before they're 10, but not diagnosed before they're 6. And you do not diagnose this in your 19, 20-year-olds. Disruptive mood dysregulation disorder is reserved for those that are between 6 and 18, onsets before the age of 10. And some of the screening tools you can use would be the Mood Disorder Questionnaire for adolescents. You can use the Parent General Behavior Inventory. You can also use the Parent Young Mania Rating Scale. And there is no approved FDA medications for disruptive mood dysregulation disorder. Next, we will move on to suicide. So what are some of the facts about suicide? The highest rate of suicide is among Native Americans, and whites have a higher incidence of suicide than African Americans, and 60% of adolescents report having suicide ideations, whereas there's 30% report attempting suicide. When we look at how are they doing this, they are overdosing on medications. And if they are using acetaminophen, it's fatal. Depending on how much acetaminophen they take, they may have a liver toxicity. There's also wrist cutting. In the United States, firearms has the greatest use. And outside of the United States, it's by hanging. Some of the medical conditions that may have adolescents, children prone to suicide would be migraine headaches, epilepsy, inflammation, and bowel disorders. And I'll tell you a little something about migraine headaches or cluster headaches. And this is from experience, not mine, but a coworker. Her father was diagnosed with cluster headaches, and he did not have them long, but those headaches were so horrible that a very successful contractor drove himself to a field, put a gun to his head, and killed himself. Very successful. Daughter's a nurse. He wasn't diagnosed until he was older, but the migraine, the cluster headaches were so bad that he could not tolerate them, that he ended his life. So when they're talking about migraine headaches, these are not just your everyday migraine headaches. These are the headaches these children have no relief from, and they find no recourse, and nothing is helping. And it leads them to suicide. There is no definitive psychosocial or pharmacological treatment for suicidal behavior. So you can't wish it away. You can't treat it away. You can calm them down. You can talk to them. But one of the best things you can do is look your client, your teen, your child in the face and ask them if they're thinking about killing themselves, if they're thinking about harming themselves, and if so, do they have a plan? Have they thought this out? Avoiding the question is not going to make their suicidal ideations go away. So when we talk about suicide and self-injury, we also want to mention the non-suicidal self-injurious behavior, which is cutting. If you have a client that cuts, investigate. Are they cutting because they want to kill themselves? Are they cutting to relieve stress? Why are they doing this self-injurious behavior? I had a client today who told me that she is, in her words exactly, 2 years sober from cutting. And I hadn't thought of it that way. But for a person who cuts, when they stop, it is like stopping a drug for them, because they're doing this as a means of, it could be stress relief, it could be acting out, they could be testing the waters that maybe they want to kill themselves. We don't know. So investigate. If you have a cutter, investigate that cutting behavior. And we'll move on to early onset bipolar disorder. It is difficult to distinguish between mania and ADHD for bipolar disorder. And there were definitely providers who were overdiagnosing bipolar in children. Please, 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 before you label a child with bipolar disorder, really know if this child is bipolar. Do they have ADHD? Is there something else that is causing this behavior in this child? It could be medication activation. Bipolar for children is not usually one of your very first diagnoses. Relying on symptoms alone may cause increased rates of diagnosis in children. So see page 3686 for more information on early onset bipolar disorder. The DSM-5 requirements are that, let's see, an abnormal or persistently elevated, expansive, or irritable mood. Those are some of the requirements for early onset bipolar disorder, is the abnormal and persistently elevated, expansive, or irritable mood. They also have persistently increased goal-directed activity or energy. So this is that child that's not sleeping and they are getting things done. They are working it. Man, they are painting, they are shooting basketball, they are cleaning their room, they're helping mom in the kitchen. They are like all over the place. They are here, there, everywhere, and they are not sleeping, and they are totally wired. Not just your ADHD hyperactivity wired. This is a completely different wire. And so this change must be a significant degree of a change from what they would normally have if they're a hyperactive child. And this observable change is from their normal, usual hyper behavior. What are some of the symptoms of early onset? They have a distance period where they are not their usual self. So again, you may have a hyperactive child, but this is well above. This is like from that 0 to 100 that your patients may tell you about. This is not usual for this child. Again, abnormally and persistently elevated, expansive, or irritable mood, persistently increased goal-directed activity or energy. Plus, they should have at least 3 of these, 4 if the mood is only irritable. So if you have just an irritable mood, then they should also have the inflated self-esteem or grandiosity, a decreased need for sleep, pressured speech, flight of ideas, very distractible, increased activity in work or socially, the psychomotor agitation, excessive involvement in activities with a high potential for painful consequences. So they have no consequences for their actions. So children are a little bit different than adults, but you may still have a sexually promiscuous female or male in that bipolar state, to where you may have a young teenage girl and she's the one that everybody's talking about with the football team. Rumors are going around. She's with all these boys. This child needs to be investigated. All of her behavior, especially if it's something new, something unusual, not their usual self abnormally, persistently elevated, expansive mood. So she is on top of the world. All of a sudden, hey, oh my goodness, I'm all over the place. Like, she is the most beautiful girl in school. She is the best girl in school. Everybody wants her, so she's with all the boys. And that's not her normal behavior. So to meet full criteria, symptoms must last for 1 full week for mania, for hypomania, 4 days. And mood disturbances must cause sufficiently severity to cause marked or social or occupational functioning or hospitalization. So if they're in the hospital, if they've been put in the hospital because this child is so uncontrollable, excuse me, y'all, I have been sick, so I apologize. If they're in the hospital, that is a clear indicator something's going on, and that child might get diagnosed and not overdiagnosed with bipolar. So if they are depressive disorder with mixed features, then there may be a coexistence of 3 manic symptoms, and for full mania, they would have a coexistence of 3 depressive symptoms. Some comorbid conditions, like I mentioned before, is ADHD. And some children with ADHD are often misdiagnosed with bipolar disorder. Oppositional defiant or conduct disorder, depression and anxiety. And there are medications that we use to treat children who are bipolar, and these medications mimic some of the adult medications, where you may be using lithium, you may use olanzapine, quetiapine, you may use chlorpromazine, sorry about that, y'all, risperidone, aripiprazole, or acenapine. So if your patient is between the ages of 10 and 17 years old, then you want to stick to the quetiapine, the risperidone, the aripiprazole, or the acenapine. Some clinical pearls for childhood schizophrenia, also see page 37D1. The onset of schizophrenia is usually not before the age of 17. It's termed early onset schizophrenia. And if you have to treat with a medication, you want to treat with the lowest effective dose. Children are more prone to developing EPS symptoms, and they're also more prone to experience weight gain and metabolic symptoms. So if you have a child who you're treating for childhood schizophrenia, the likelihood of them staying on that medication after they've gained weight is low, especially for females. They are not going to want to be on any medication that is making them gain weight. Also, antipsychotic drugs started on children when they're young may impair their learning. And the prognosis for early onset schizophrenia in children is worse than adult schizophrenia. So if they are diagnosed young, their prognosis is worse. Some of the positive symptoms that they may experience would be the hallucinations, the delusions, the illogical changes in behavior or thoughts, or hyperactivity. And some of the negative symptoms they may experience would be the apathy, lethargy, withdrawal from social events. They may have that blunted effect, or they may have the reduced experience of pleasure. and that is just a repeat of the slide. So if you'd like to take a pause before we go into our next section, this has been a little bit over 30 minutes, so you can take a quick break and we will be right back. Okay, our next section is gender dysphoria. Gender dysphoria in children can only be made if children meet two of the criteria that we will be going over. They also have 8 manifestations in criteria A, which 6 must be met. And one of those 6 must be a strong desire to be of the other gender or an insistence that he or she is of the other gender. So what are some of these features? Well, they must have, again, a strong desire to be of the other gender, insistence that one is the other gender, a healthy aspiration to have the sex characteristics of a different gender, whether it's primary or secondary, a healthy desire to have friends of the opposite gender, pretending to be a different gender, choosing to play games or with toys known to be geared towards the opposite gender. So little boys may have a sister and they want to play with their dolls. That's not necessarily choosing to play games with a toy geared to the other gender because they're playing with their sister. You may have a little boy who does not have any sisters, and all they want to do is play dolls, put mommy's makeup on, wear mommy's shoes, wear mommy's dresses, play with just the little girls in the neighborhood. That may be something that warrants a little bit more investigation. They have an opposition towards stereotypical sex-assigned activities or toys. And they have a healthy distaste for the genitals of their assigned gender. And again, they may prefer to dress as the opposite gender. So these symptoms must be present for at least 6 months. The dysphoria must cause considerable torment in the essential functioning. It must be clinically significant distress or impairment in function, social, occupational, or other areas. And children must have 6 of the 8 symptoms, again, with one of them being a strong desire to be of the other gender or an instance that one is the other gender or some alternative gender from their assigned gender. Some children label themselves by the other gender as early as 2 to 3 years of age. And children, however, do not recognize the gender constant until they're around 6 to 7 years of age. So again, a child may label themselves by the other gender by the time they're 2 to 3, but children don't recognize gender constant until they're about 6 to 7 years old. So management of gender dysphoria that's persisted from childhood is straightforward. It's more straightforward than management of gender dysphoria when they're later. You want to find out, who are you when you're talking to your client? You want to know who they are. How do they identify? Age, biological sex, relationship status, and we're talking about teens. Their current functioning, are they satisfied or unsatisfied? Their dysfunctions, their sexual frequency, and children, not little children, adolescents, are having intercourse at younger ages, same sex at younger ages. What are their desires? Any sexual compulsivity? In their sexual history, you can get their parental viewpoints regarding sex, nudity, modesty. What about sex education? Any observations of sexual encounters? And I've recently been taking care of a 15-year-old male client who has a propensity to watch porn. And so his father recently took his cell phone and took him off of social media because not only was he watching porn, he was trying to get young girls in his class to send him nude pictures. So you want to know, I talked to the father first. I talked to the young boy. The young boy really doesn't admit to this going on. However, it was on his phone. So here we are, probably 7 to 8 months later, and he doesn't have the access to watch porn anymore, and he doesn't even admit that he ever watched porn. If you have an adolescent with a recent onset, they should be screened carefully to detect if something has gone on. Has there been some kind of trauma? Check for any mania, schizophrenia, psychotic depression, something that may start to produce gender confusion, because you may have a child who has been traumatized by someone of that same sex, and then they get the confusion that maybe that's the sex they should be with. I do have a couple of, actually two, when I say a couple, I actually mean two male clients who have been hospitalized because they have sexually assaulted their younger brothers. So these are males who have sexually assaulted their younger brothers. So those younger brothers weren't watching because maybe they will think that they may have some gender confusion. So they may think that, okay, this is the sex that I'm going to be attracted to, or this is the behavior I should be modeling after, especially because the younger brothers are pretty young. One of them might be as young as 5 or 6 years old. You want to find out their activities, get an adolescent puberty assessment, like the onset age, sense of self, sex activities, sexual experience, contraception use, and coitus. Some important questions you want to ask them is, do you have a name preference? And if so, what does it mean to you? And I recently had a patient that is transgendered, and I was very confused because I was not sure she is trans. And I still don't know if she's a she or a he. My patient wants to go by the name of Kels, and that's what I will call my patient. But I can't tell which sex the patient started off first. So what I do is just call the patient by the name that they would like to be called. But it is important to know what pronouns they want to go by and respect that. You can ask them about their body parts. What part do you like? What part do you dislike? Has anyone ever mistreated you because of your gender identity? How long have you been struggling with your identity? And which identity do you prefer? I also have a 13-year-old who I think she told me they called them, I want to say emu, but maybe I have that name wrong. And back when I was in school, which I'm going to kind of give y'all my age, back when I was in school, those kids to us were only the kids who dressed in black. There was no other association with them besides they wore all black to school. They had black hair, black fingernails, dark black makeup, all black clothes. That's all we knew of them. Now, that is associated with homosexuality and transgender, and those children are bullied, according to one of my clients. So we definitely want to consider family, and we want to respect family members' viewpoints. In different states, I've had parents in Washington and Oregon who are very open to their children's sexuality. If the child wants to use the pronouns them, their, they, that is what the parents respect. If it's a female and the female wants to be he or him, the parents respect that. If it's a male who wants to be she and her, parents respect that. If the parent does not, we also have to respect the parent's wishes. So not all parents are going to be open to their children's sexuality. It cannot be forced on them. And we just have to learn to incorporate the family when the family is ready. How can we help the family? Well, we can explain what gender dysphoria is. We can educate them on the different gender-affirming terminology. Definitely emphasize the importance of family support. Discuss options for family therapy and counseling. Acknowledge the challenge to family beliefs, because again, we're treating the client and we're definitely going to respect the client, but we also have to definitely respect the family. So you have to acknowledge if that family is not ready to participate in that care. And we just hope that at some point they will. Some children's family members will come on board and some families never will. We want to tell them the best times to communicate with their youth. If that youth is ready to talk, then hopefully the family members are ready to listen. And we just kind of discuss the process with them, because this could be new to them. And again, different cultures, different beliefs, different people. So everybody reacts differently. Our main focus, of course, is that client. But if we can incorporate that family, or at least reach out to that family to try and educate them or refer them, it will definitely help our client as well. So what is the age of consent? In Louisiana, a 16-year-old can consent to their own mental health treatment. And the law doesn't clarify inpatient or outpatient. Louisiana allows minors to consent to their own medical care without telling their parents, but that is for pregnancy and childbirth and sexually transmitted infections. So, and there's special rules about abortion and sterilization, of course. The statute does not set a lower limit on the age of minor who may consent, and there's no case law that sets a minimum age of consent. And physicians, providers are protected from liability for relying on the consent of a minor. Remember, that is for medical treatment for emergencies. If the patient is a minor, the doctor is not required to tell the parents or guardians about their care unless it's in their best interest, even if they don't want them to. So if the parents disagree about that child's care, then the parent's decision is final. And a parent can consent to the care of their minor children, even if the parent is a minor. So again, in Louisiana, a 16-year-old can consent to their own mental health treatment. All of that to say, can a minor consent for hormone treatment and or gender assignment surgery? No, they cannot. That is not a medical emergency. It's not falling under pregnancy, childbirth, or STDs. So you cannot have a 16 or 17-year-old consent to have gender reassignment surgery. If your patient is considering surgery, some things you want to know are, is there a history of trauma? Do they have a history of mental disorders like schizophrenia, mania, psychotic depression, and be very familiar with your state laws? Someone who is 18 or older can consent to have surgery. They have to have the capacity to make a fully informed decision and consent. There's got to be, if they have any significant medical or psychiatric conditions, they have to be well controlled. They have to live 12 months in the desired role of the sex they want to change their reassignment to. They have to have 12 months of hormone therapy, and they will need referrals from 2 qualified mental health providers, which is that is where you're going to come in. So if you've been treating a 19-year-old, 18-year-old since they were 16, any patient, then you may be asked to give a referral for your patient to have gender reassignment surgery. Some clinical considerations is that our transgendered population is at increased risk for violence, and this has been on the rise, definitely in Louisiana, definitely in Texas. In the last several months, so many of our transgendered patients are losing their lives because of just the hatred towards their community. Because of prejudice, they may have barriers to health care. So they may have poor physical health, poor mental health, and they are at increased risk for suicide. Excuse my misspelling on mental, y'all. I'm sorry, I'm trying to get these lectures to y'all. But we need to provide a safe space for our clients to come and feel comfortable coming to get the treatment that they need. So it is definitely a safe haven that we need to provide if you have a transgendered patient. And I know everyone is entitled to their own beliefs, but to treat people in our field, sometimes we have to put those beliefs to the side just to provide some care. You don't have to change your beliefs, but we do have patients that may come to see us that need our care, and our field is so limited already that we should not be turning people away who need treatment. And another statistic that I forgot to give you is that 25 to 43% of transgender adults have reported a suicide attempt in their lifetime. Now, some key takeaways is that we want to form a therapeutic relationship. We want patients to feel comfortable. Don't be afraid to ask questions. Be open and don't judge. Know your state laws. Respect your patient. Respect your patient's family, and know when to refer. And that is it on gender dysphoria. If you want to take a break, we only have sleep-wake disorders left to go over. And this is sleep-wake disorders, which you can find information in chapter 55 on pediatric sleep disorders. This is very brief, 8 slides, good information, testable information. Some sleep-wake disorders include insomnia, hypersomnolence, narcolepsy, breathing-related sleep disorders, circadian rhythm disorders, non-rapid eye movement, sleep behavioral arousal disorders. You have nightmare disorders, rapid eye movement, sleep behavior disorders, restless leg disorder, and substance medication-induced sleep. We will not cover all of these for this unit, but these are some of the sleep-wake disorders. There's different sleep stages, which we have the REM sleep, which is typically a story-like dreams occur in this sleep, and it occupies about 20 to 25% of the total sleep. You have the non-REM, which is the sleep stage 1 non-REM sleep. So there's different non-REM stages. This is sleep stage 1, which is a transition from wakefulness to sleep. It occupies about 5% of the time spent in healthy adults. We have non-REM sleep stage 2 that occupies about 50% of the time asleep. And we have non-REM sleep stage 3. That is a slow wake sleep. Sorry for the misspelling. It is the deepest level of sleep, and it occupies about 20% of the sleep time in healthy younger adults. Some adults or children may complain of difficulty initiating sleep, difficulty maintaining sleep, or an early morning awakening with an inability to return to sleep. So they may have trouble falling asleep and they wake up at 2 o'clock in the morning. They can't go back to sleep till 3 or 4. They finally think they're back to sleep. It's 5 o'clock. It's time to wake up. So that is a sleep distressful cycle. The sleep disturbance causes clinically significant distress or impairment in either school, work, educational, academic, behavioral, or other important areas of functioning. And to be diagnosed, they have to have a sleep difficulty that occurs at least 3 nights a week, and it must be present for at least 3 months. And the sleep difficulty occurs despite adequate opportunity for sleep. Also, it cannot be better explained by another sleep-wake cycle. It cannot be attributable to any physiological effects of substance abuse or even medications. The coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. So I'll talk about some of the definitions that you'll want to know, like parasomnia, and that is the complaint of unusual behavior or events during sleep that may lead to some intermittent awakenings, and that is sleepwalking. Okay, back to the parasomnia, sleepwalking. Hypersomnolence disorder, that would be an excessive sleepiness despite having a sleep period that lasts about 7 hours. So that's your hypersomnolence. Some sleep-wake pearls that I would like you to know is that 25% of children will suffer from a sleep problem. Orexin is said to have an increased effect on the sleep-wake cycle. Persistent insomnia in children may be a sign of emotional distress. And there are some survey instruments that you can use for your clients, and they include the Sleep Disturbance Scale, the Child and Family History Questionnaire, Sleep Disorders Inventory for Children, Sleep Diaries. If you're going to use the sleep diaries, you definitely want to have about 2 weeks of sleep logs. And the Epworth Sleepiness Scale, modified for children and adolescents. How do we treat these children with sleep disorders? Good sleep, hygiene, and behavioral interventions are the first line treatment for pediatric insomnia. Good sleep hygiene and behavioral interventions are the first line treatment for pediatric insomnia. You want to educate, and we'll talk about medications. But when we talk about educating them, educating the parent, educating the child, we talk about stimulus control. So you want them to remove the clocks, no cell phones, maintain a quiet sleep environment. Sleep restriction, so limit the amount of time in bed until the child is sleeping about 90% of the time in bed. The circadian rhythm maintenance, whereas they're going to bed and waking up at the same time each day. You may want them to avoid do sleep hygiene, I'm sorry. You may want to address cognitive distortions. And what I mean by that is if I don't go to bed soon, I'll be a complete wreck. Like, they are having these distortions. They can't sleep because they're watching that clock. They're like, oh my God, I can't sleep. I'm going to be a wreck. This is not going to work. Oh my God, if I don't go to sleep, I'm never going to get up in the morning. Oh my God, I'm going to fail my test. Those cognitive distortions. Also, arousal reduction. So you want to discuss relaxation techniques such as belly breathing, biofeedback, maybe a warm bath, warm tea before they get into bed. If you consider medications, consider that there are no FDA-approved medications for the treatment of sleep disorder in children. However, melatonin has been studied and has been deemed safe to use. And some providers may also use clonidine for sleep. I always say to educate first if you can. Medications like Ambien, Lunesta, temazepam, those medications have no research to back them to prescribe them for children. And this concludes your information and lecture for Module 3. If it was discussed in the lecture, then please look up a little bit more information on it in your books. If I have discussed it in the lecture, then that is what we will use for your exam. So if you find some other resource, some article, it's not relevant. There's different sources. So if I'm telling you that there's no FDA approved medications for sleep, as per our textbooks, then if you find something online that says there is, we are going by the textbook. So please take the time to listen to your lectures. There will be a test analysis that will be completed after everyone has taken the exam. You have 75 minutes to take a 50-question exam. Please do not send any emails until after 1 o'clock, because I will, after everyone has taken the test, I will do a test analysis. If your grade will not change, then challenging a question or two is not going to be beneficial to you. If it does make a difference and it is in this lecture and it's not, if it's in the lecture and you see it on your exam, go back to the lecture. Again, lecture or book or anything that's been posted in your modules, that is all I am considering for your exam. Alrighty, y'all have a happy Thanksgiving and study well. I'm sure you will all do great.